Good morning. The topic of this lecture is bone infections or osteomyelitis. The learning objectives are listed on this slide. We will discuss the etiology, epidemiology, and pathogenesis of osteomyelitis, describe common types of osteomyelitis, emphasize the importance of accurate diagnosis for improving outcome of patients with osteomyelitis, and emphasize the importance of collaboration and communication among the professional team and the patient. The lecture is divided in three parts. In the first part, I will discuss the epidemiology, etiology, microbiology, and pathogenesis of osteomyelitis. In the second part, I will concentrate on some common types of osteomyelitis like hematogenous osteomyelitis in children, vertebral osteomyelitis in adults, osteomyelitis after trauma or surgery, prosthetic joint implant-related osteomyelitis, and diabetic foot infections. In the third part, we'll talk about the management of osteomyelitis, concentrating on diagnostic tools, surgical interventions, antibiotic therapy, preventive measures, and lastly, take-home messages. The skeleton is a structural frame that supports the body. Bone infection is called osteomyelitis. The term was coined by Nelaton in 1844, with osteon referring to bone, myelo referring to marrow, itis, inflammation. Any bone may be affected. Osteomyelitis may be a mild disease or may lead to bone necrosis and sepsis. There are two major forms of osteomyelitis. Acute osteomyelitis, which presents with pain, fever, and limited function of the affected area. Chronic osteomyelitis that presents subtly with persistent or intermittent bone pain, swelling, and possibly sinus tract formation. Risk factors include trauma, presence of foreign body, orthopedic surgery, and immunosuppression. Osteomyelitis is an ancient disease with fossilized evidence of animal infection hundreds of millions of years ago. Discussion of human osteomyelitis dates to the time of Hippocrates, 460 to 370 BC. Classification of osteomyelitis is needed for treatment planning, prognostication, and clinical studies. Around 50,000 cases are diagnosed annually in the United States of America. The incidence is higher in man and increases with age. The availability of sensitive imaging such as magnetic resonance, MRI, and bone scintigraphy has improved the diagnosis accuracy and the ability to characterize the infection. Healthy, intact bone is resistant to infection. But the bone becomes susceptible to disease with the introduction of large inoculum of bacteria. And this is done by following trauma with open wounds, ischemia as in diabetes, or the presence of foreign body after surgery. Staphylococcus aureus and other bacteria adhere to the bone by expressing adhesions for some components of the bone matrix. And some bacteria also create a protective biofilm coating around themselves and underlying surfaces to resist the action of antimicrobials. Intracellular survival of some bacteria may explain the persistence of bone infection and high failure rate of shorter courses of antimicrobial treatment. The attributes of Staphylococcus that make it the most common organism in osteomyelitis are listed on this slide. Staph aureus and Staph epidermidis are part of the normal skin flora, so they are available everywhere. They have the ability to adhere and they have several adhesions. They have the ability to evade from host defenses and the ability to produce exotoxins and ability to invade mammalian cells. And they have the capacity for hibernation and they can persist for decades. And they produce also biofilms. Other pathogens can also cause osteomyelitis, and there are many gram-positive and gram-negative bacteria, fungi, mycobacteria, and others. But the most common organism causing osteomyelitis is Staphylococcus aureus and Staphylococcus epidermidis. On the left side is a scanning electron micrograph of Staphylococcus aureus cells surrounding a magnetic bead. The bone may be infected via several mechanisms. One, bacteremia, resulting from infection in a distant focus and then seeding the metaphysis of long bones in children and vertebral bodies in adults. The second mechanism is contiguous spread from surrounding tissues or joints. In young adults, this is usually after trauma and related surgery. In older adults, it may be secondary to decubitus ulcers and infected joint arthroplasties. Third method is direct inoculation of bone during operative procedures and placing hardwares. The fourth way is via vascular insufficiency will make the bone highly susceptible to infection. Example, diabetic foot or decubitus ulcers. On this slide, there is a schematic representation of the pathogenesis of acute osteomyelitis in children. As you can see here, there will be slowing of the blood flow and the possibility of establishing an infection at this site. This infection will increase further and will open to the subperiosteal space. And in the meantime, a part of the bone will be necrosed. And this will be osteomyelitis. Next, I will review some common types of osteomyelitis, starting with hematogenous osteomyelitis in children, vertebral osteomyelitis, osteomyelitis after trauma or surgery, prosthetic joint implant-related osteomyelitis, diabetic foot infection. We'll illustrate hematogenous osteomyelitis in children by presenting this case. A six-year-old boy presents with a week of fever and refusal to walk due to pain in his right leg. Initial suspicion is for juvenile rheumatoid arthritis or a traumatic injury. Lab results show elevated ASR and CRP. X-ray is initially normal, but an MRI reveals changes consistent with osteomyelitis in the right femur. Staphylococcus aureus was isolated from blood cultures. In children, the most common type of osteomyelitis is hematogenous and typically involves the metaphysis of long bones. As we said also, in adults, it typically involves the vertebral column. More than 50% of cases occur in children below the age of 5 years, with higher incidence in developing countries as opposed to developed countries. Boys to girls ratio is 2 to 1, and the risk factors include sickle cell disease, immune deficiency, sepsis, mild trauma with bacteremia, indwelling of vascular catheters. Primary foci of infections are identified in around 50% of cases and include complicated UTI, skin soft tissue infections, and IV catheter infections and endocarditis. In the early stages of acute hematogenous osteomyelitis, children often present with vague symptoms of fever and malaise. The symptoms may seem benign, and a misdiagnosis of a muscle strain may be made. No soft tissue swelling initially, followed by local swelling and pain and bone tenderness. Older children who can give a good history may be able to localize their symptoms. If the lower extremity is affected, they may ambulate with an antalgic gait, limping, spend less standing time on affected leg during walking. Younger children, however, tend to stop bearing weight soon after the onset of pain. If the upper extremity is involved, parents may note pseudo-paralysis of the affected extremity. Blood culture is usually positive, and the femur and tibia are the most often affected bones. On the right side, this is a skeleton, and with different percentages of involvement, bony involvement, with femur and tibia topping the list. I'll start by presenting a case of vertebral osteomyelitis. The patient is a 65-year-old woman with diabetes who presents with persistent low back pain and recent onset of fever. Differential diagnoses include lumbar spondylosis, metastatic malignancy, and epidural abscess. ESR and CRP are elevated. X-ray shows mild degenerative changes. An MRI reveals a vertebral infection and adjacent soft tissue involvement. Bone biopsy confirms the diagnosis of osteomyelitis with culture positive for Staphylococcus aureus. Many names are given to vertebral osteomyelitis: disc space infection, septic discitis, spondylodiscitis, or spinal osteomyelitis. Vertebral osteomyelitis is caused by a bacterial infection of the vertebral bodies that can extend into the adjacent intervertebral disc spaces. The incidence rate increased over the past 2 decades because of improved technology and increased use of invasive interventions like long-term IV catheter and spinal instrumentation. An age-dependent increase in incidence is noted, with a mean age of 66 years and a male-to-female ratio of 1.5 to 1. Vertebral osteomyelitis carries a significant morbidity and mortality, with a median length of stay in the hospital of 1 month or more. Bacterial inoculation in vertebral osteomyelitis occurs through two main pathways: hematogenous seeding, which accounts for 50% of cases, and direct inoculation, which accounts for 15 to 40% of cases. The mechanism can occur after routine spine procedures such as lumbar puncture, discography, laminectomy, discectomy, or any other spinal intervention. Less commonly, bacterial inoculation occurs through local extension from adjacent areas of infection. It's 3% of the cases, including retropharyngeal abscesses or infected aortic graft. In hematogenous vertebral osteomyelitis, there is deposition of microbes in the metaphysis of the vertebral bodies during a bacteremia. The infection then spread to the intervertebral disc, which is an avascular structure. Then the infection spread to the adjacent vertebral bodies supplied by splitting arteries from a single vertebral artery. Also, venous drainage via Batson's plexus is felt by some experts to contribute to spondylodiscitis metastasizing from a urinary tract focus. Vertebral osteomyelitis may be classified as hematogenous, which is the most frequent type, and post-surgical early onset, and post-surgical late onset. Each type has different presentations and characteristics. Patients with hematogenous vertebral osteomyelitis complain of localized back pain and tenderness that may mimic an early herniated disc, but the presence of fever should always raise the possibility of infection. Pain is worse at night. Pain begins insidiously and progressively worsens over several weeks to months. The lumbar spine is affected in 60% of the cases, dorsal spine in 30%, and cervical spine in 10%. In the lumbar spine, it is maybe called febrile lumbago or backache, and the neck, torticollis. In the early onset, less than 30 days post-surgical infection, the presentation is impairment of wound healing and fever. In late onset, more than 30 days post-surgical, the presentation is a sinus tract formation, pain, and maybe a focal neurological sign, but fever is rare. Now, I'll present a case to illustrate osteomyelitis after trauma or surgery. The patient is a 36-year-old male who sustained a fall that resulted in close, comminuted fracture of his right tibia. The patient underwent open reduction of the tibia and placement of plate and screws. He received intravenous cefazolin for 5 days. Around 3 weeks post-surgery, he presented with pain, swelling, and discharge from site of surgery. He was febrile and complained of chills. Hematogenous seeding is a less common mechanism in the setting of trauma and surgery. Osteomyelitis may develop as a result of contamination of open fractures or open repair of closed fractures. In closed fractures, the overlying skin is intact, whereas in open fractures, the skin is injured and sometimes the bone is showing. The risk of infection of closed fracture or implant-associated infections is less than 1%. However, the risk of infection in open fractures may reach up to 30% and depends on several factors, which include the severity of the fracture, severity of the soft tissue injury, size of bacterial inoculum, the vascular supply to the area, adequacy of debridement, and administration of prophylactic antibiotics. The clinical presentation of acute post-traumatic osteomyelitis is one of poor wound healing and fracture non-union. Fever, wound drainage, warmth, pain, and erythema may occur. Diagnosis involves, as in other settings, a combination of clinical signs, laboratory markers, microbiology, and histopathology from biopsy specimen, and also imaging studies. Delayed or late infections or chronic infections are secondary to ineffective treatment of acute infection or an infection caused by a low virulence microorganism. These infections may present with local swelling, bone pain without skin lesions, or with persistent sinus tract or exposed bone. Sometimes there is tissue necrosis overlying bone or a chronic wound overlying the fracture or surgical hardware or exposed hardware. Next, I will discuss prosthetic joint implant-related osteomyelitis. Elderly population is increasing, and this is followed by increasing number of the need for joint replacement. Around 1 million hip replacement per year is done in the United States of America alone. In addition, there are knee replacement and other joint replacement. The risk of perioperative infection of the joint is less than 1% in good centers. However, the risk of hematogenous prosthetic joint infection may remain throughout life, and although it is higher in the early post-operative period, and it is highest during Staph aureus bacteremia, reaching up 30 to 40%. Concerning the pathogenesis of prosthetic joint infections, the implanted foreign material or prosthesis is highly susceptible to infection because it is a foreign body and local immunodeficiency around it. The infection may occur at the time of implantation or later by hematogenous route. Rarely, the joint may be infected secondary to a contiguous deep soft tissue or bone infection. Foreign devices are usually covered with host proteins like fibronectin that favors bacterial adherence and thus promotes the possibility of infection. The risk factors for prosthetic joint infections increase in the presence of comorbidities like rheumatoid arthritis, diabetes mellitus, malignancy, CKD, obesity, lymphedema, immunosuppression, use of prednisone or tumor necrosis factor inhibitors and other biological drugs. It is also increased with prior arthroplasty or prior infection at the surgical site. It is also increased if surgery is prolonged and depending on the surgical skills. A good surgeon will have less risk of infection as a less trained surgeon. Post-operative complications such as hematoma and wound dehiscence will increase the risk of joint infection. And of course, if the patient develops Staphylococcus aureus bacteremia, the risk is high for joint infection. The burden of joint infections is high and can be divided as on this slide to impaired quality of life. There is loss of joint function, prolonged hospitalization with its direct cost and indirect cost, ongoing pain management and the side effects of the drug, and the negative psychological effect. Prosthetic joint infections should be differentiated from other conditions. One is aseptic loosening of the joint, but even with aseptic loosening, about 12% have an underlying prosthetic joint infection. Joint instability, component malposition, inflammatory arthritis, crystalline arthropathy, gout or pseudogout, adverse local tissue reaction, wear osteolysis. All of these conditions may mimic a prosthetic joint infection, and it is very important to make an accurate diagnosis. Now I want to discuss diabetic foot ulcers. To start with, we have to mention that the prevalence of diabetes mellitus around the world in 2021 is estimated at 537 million adults aged between 20 and 79 years. This number is predicted to rise by 2030 to 643 million. 3 out of 4 adults with diabetes mellitus live in low and middle income countries. I will illustrate the discussion by this case presentation. The patient is a 70-year-old diabetic male who is presenting because of injury to his left big toe while attempting to cut his nails 4 weeks earlier. Patient is afebrile and complains only of persistent discharge from his toe. No pain or erythema. His blood sugar and hemoglobin A1C are high. He admits that he does not adhere to the prescribed medication nor his diet. This is a typical case of diabetes mellitus who neglects himself or who is neglected. Diabetic foot ulcer is unusual below the age of 40. Above 40, it starts and increases with increasing age. Males are more affected than females. And of course, there is a higher incidence in developing countries and especially in lower socioeconomic groups. 20 to 60% of patients with diabetic foot infection have confirmed osteomyelitis because, as we mentioned in the case that I presented, they come late and during this time they develop osteomyelitis. And once there is a diabetic foot osteomyelitis, the risk of amputation increases. Adequate management at an early stage of the diabetic foot ulcer will lower the rate of amputation. Osteomyelitis in patients with diabetes mellitus is multifactorial. Patients with diabetes mellitus will have a sensory neuropathy. They may not feel the pain or heat as normal persons, and they may develop skin ulceration at point of pressures or trauma without noticing it. Following this ulceration, there is colonization with skin flora or pathogenic flora. Second problem in diabetes is poor vascular supply, especially in the lower extremity. So, if you have poor vascular supply, there will be compromise for the local immunity and skin healing, and it will be easier for the infection to spread to underlying tissues or bone. Patients with diabetes may have additional disabilities like decreased vision, which will lead to trauma or fall down. And because most of the cases comes from a low socioeconomical classes, there is lack of support, poverty, ignorance, and healthcare system failure in poor countries. Presenting symptoms and signs of diabetic foot ulcers depend on the extent of neuropathy and vascular insufficiency. Pain and signs of cellulitis may be absent or minimal, and there are different types of presentation that are listed on this slide. So the patient may present with painless ulcers or only soiling of socks and footwear, or his ulcers may be painful and or he will present with ischemic foot ulcers. He may present with difficulty in walking. He did not notice the ulcers before. He may have sensory deficit. There may be swelling and deformity or bony prominence, and he may have ingrowing toenails, corns, or calluses. Color change may be secondary to the vascular insufficiency, lack or loss of hair growth on the leg and foot, but this does not lead to ulceration, but it will tell you that there is a problem with the circulation, as well as if the feet are cold or if you feel the pulses and they are absent. Sometimes they present late with toe, foot, or even leg gangrene. And of course, in all of these cases, uncontrolled blood sugar may be one of the presentation. And the severe presentations may be sepsis or septic shock. On the right side, I illustrated two common findings in diabetic foot ulcer. Patients confined to bed or a wheelchair by paralysis or debility are subject to pressure-related skin ulceration and necrosis, most commonly in the sacral and buttock areas. These ulcerations are colonized frequently by polymicrobial flora emanating from the skin and gastrointestinal tract, with soft tissue infections spreading to the bones of the pelvis and lower extremities. So the prevalence in nursing home is around 6%. And common anatomical sites of pressure ulcers are sacrum, greater trochanter, and heels. As we said, it starts as a soft tissue infection and then spread to the underlying bone of the pelvis and lower extremities. Risk factors of pressure ulcers are poor nutrition, incontinence, age, diabetes mellitus, stroke, skin abnormality, male sex, and extrinsic factors such as pressure, friction, shear stress, and moisture. Now I'll start the third part of the lecture, which is the management of osteomyelitis. Osteomyelitis, as you know by now, it is a severe disease and has many complications and require the help of many specialties. We have to formulate a management plan. The management plan should involve the patient or his guardian because of possible complications and debilities. It has to involve, of course, an orthopedic surgeon and a vascular surgeon, and an infectious disease person and an endocrinologist in the cases of diabetes mellitus, and nephrology because of the complication of diabetes on renal failure and on the use of prolonged courses of antibiotics. The laboratory, radiology, pharmacy, and nursing plays an important role because it is essential to establish a correct bacteriological diagnosis and to determine the susceptibility of the organisms. Otherwise, we have to resort to broad spectrum antibiotics, which is resulting side effects and to the patient and to the community. I want to stress again the importance of to identify the causative pathogen because it is very helpful in planning antimicrobial selection. It is helpful for stewardship and avoidance of broad-spectrum antimicrobials with all their side effects. And it promotes better clinical outcomes if we use a targeted treatment. And it offers the patient peace of mind and clearer clinical management plan. So he knows what is the organism and how it is being treated and what the prognosis of his disease. The first step in the management of osteomyelitis is to suspect osteomyelitis. By history, how to suspect acute or chronic osteomyelitis. In acute osteomyelitis, the onset is few days to within 2 weeks. There is erythema, swelling, and warmth at the site of infection. Dull pain with or without motion may be noted. Sometimes there is constitutional symptoms such as fever or chills. So if you have this and you suspect osteomyelitis, this is the first step. For chronic osteomyelitis, symptoms for more than 2 weeks, which include swelling, pain, and erythema at the site of infection. Constitutional symptoms like fever are less common. So moving to the physical exam, we have to look for a possible nidus of infection. We have to assess the sensory function, especially in patients with diabetes, and to assess the peripheral vasculature, again in diabetes or other diseases that will cause a problem with the vascular supply, mainly to the lower extremities. And by palpation of the spine, we can look for tenderness, or palpation of bones to look for tenderness. If you see a diabetic foot ulcer and you are able to probe the ulcer with a blunt sterile instrument reaching the bone, this is a highly suggestive of osteomyelitis. You should highly suspect osteomyelitis in the following situation. If you can detect bacteremia or endocarditis, so you can have hematogenous spread to bones, as we mentioned earlier, يعني hematogenous osteomyelitis in children and in adults. IV drug users are also prone to develop bacteremias, and this will lead to osteomyelitis. Trauma to a specific bone, and subsequently, even if there is no fractures, there is a bacteremia, it may localize to this traumatic area. If there is a fracture, be it open fracture mainly, the risk of osteomyelitis is very high. In uncontrolled diabetes, you look always for diabetic foot ulcers. In patients with neuropathy, again, diabetic foot ulcer. Patients with peripheral vascular disease, you should also look for diabetic foot ulcers in the lower extremity. Patients with sickle cell disease or patients who have chronic ulcerated wounds, erythema, soft tissue infection, bony tenderness, joint effusion, decreased range of motion, and especially exposed bone should be highly suspected to have osteomyelitis. So we said the first step is to suspect osteomyelitis. The second step is to establish the diagnosis of osteomyelitis. Some laboratory studies are helpful, like CBC, ESR, and CRP. Yani CBC may show leukocytosis, ESR is elevated, and CRP is elevated. The positive identification will be through blood culture, direct bone biopsy, or culture of an intraoperative specimen. Specimens from sinus tract or open wounds are misleading because they don't reflect usually the true pathogen. The concordance between a sinus tract culture and a deep culture is high if you recover Staph aureus. Otherwise, there is no concordance between the two specimens. If you suspect an implant infection like a knee infection, knee joint infection, prosthetic knee or prosthetic hip infection, you have to take multiple specimens to try from multiple sites and a histological exam to prove the diagnosis, because in this case, you have to prove it, and the treatment is to remove the hip joint or the knee prosthesis, which is a very expensive endeavor for the patient and monetary wise. Radiological studies that are helpful. Plain X-ray may show osteomyelitis after 10 days, 2 weeks. CT scan is more sensitive. MRI, technetium bone scan, PET scan, and leucoscan. All of these radiological studies can be used to prove the diagnosis of osteomyelitis. On the right side, I showed a skeleton of a human body and putting the sites of infection and suspected bacterial infection at that site. As you can see, Staph aureus tops the list on all sites. Now I want to concentrate on the principles of management of osteomyelitis. And I will look at it in two ways. One is a decision-making concern, and then the management. The decision-making concerns, we have to inform and educate the patient or his guardian. We have to study the health status of the patient and what he expects from the management. We have to consider the specific bone that is involved, because there is a big difference between fifth toe, if the fifth toe is involved, or the wrist or tibia or femur is involved. We have to consider the vascular supply, mainly into the lower extremity, the presence of foreign body, because in the presence of foreign body, there is no way of eradicating the infection in the bone or in the affected area. Time of injury is important because it's easier to manage if the patient comes early for management rather than late. Pathogen susceptibility is very important because we have to assess if we have an adequate, active, safe antibiotic to use for a prolonged period of time. And before we get the pathogen and its susceptibility, we have to rely on the local epidemiology in the choice of antibiotic. The management consists of a general supportive management, which means adequate caloric intake with proteins and vitamins, etc. So in surgical intervention, we have to make sure that there is a trained surgeon available and that we have an adequate facility to do the procedure. The surgeon should remove all dead bone and soft tissue, and to achieve viable vascularized environment and appropriate reconstruction of bone and soft tissue defects. The bone should be immobilized to heal, otherwise it will not heal. And there are several methods of immobilization, starting from a cast to putting a plate or with screws or rod or an external fixator. Last but not least is antibiotic therapy. It may be started as an empiric therapy based on the local epidemiology, then shifted to a directed therapy. And here we should choose or select the antibiotic that is active and safe with the least toxicity, because the course is prolonged. What are the complications of osteomyelitis? They are listed on this slide. One is persistence of infection with progression to chronic osteomyelitis. So we start with acute osteomyelitis, we cannot clear it, and it changes to a chronic type of osteomyelitis, which is very difficult to treat. And the other complication is the need for additional surgical intervention or additional antibiotic courses. And osteomyelitis is known to relapse if inadequately treated or if there is remaining dead bone or a foreign body. Other complications include bone deformity, fracture, sinus tract formation, loss of the full function of the extremity. A bad complication is local and systemic spread and dissemination of the infection. Septic arthritis may be a complication of mainly prosthetic joint infection. And of course, like other hospitalization, prolonged hospitalization and bed rest, there is the cost, the loss of work, and side effect of the drugs. Take-home message. We reviewed the epidemiology, etiology, and pathogenesis of osteomyelitis. We also reviewed some common types of osteomyelitis. Osteomyelitis is an infection that can present in various ways, thus requiring a high degree of clinical suspicion for proper diagnosis. The diagnosis of osteomyelitis involves a combination of clinical, laboratory, and imaging studies. Often a bone biopsy and culture is done for pathogen identification. Management typically requires prolonged antibiotic therapy and surgical intervention to debride necrotic bone. The proper management of osteomyelitis requires collaboration among the interprofessional team and communication with the patient or his guardian. Thank you for your attention.